And in fact, before I thank Dr. Jawahar and Academy of Hospital Administration, Noida, just prior to lunch break, Professor Jawahar came to me asking for my consent to shift my session for the post-lunch hours. I was in a dilemma. One side I was hungry and looking at the faces of audiences. Also I felt they all must will curse me if I propose that let's have before lunch. And after lunch I knew that attendance will reduce. There would be effect of lunch effect with that much sumptuous meal, including me. I also enjoyed. So extremely grateful to organizers for having invited me to talk that what work we have done and what had been the journey of quality in the country. Since morning I had been listening to the speakers where somewhere the national health account was mentioned, somewhere public health management cadre was mentioned, because these are the two domains basically at NHSRC we have been actively engaged with. And it was a rather music to my ears when I hear the discussion taking place. That okay, let's start the conversation. Any document when it comes, it needs lot of changes. And the key message which came was that in the health sector, lot of investment has been made, whether the government or non-government side, both the sides. And in terms of, if you look on this view file, the slide, where it is shown that share of the public health system, public health facilities over a period of time has also, post-independence, it was quite good. Because of successive policies, it deteriorated, and now that thing is coming back. Similarly, Dr. Lakshmi Prasad mentioned about that out-of-pocket expenditure falling. But India, the short point I want to make at this juncture is that India is still one of the countries where out-of-pocket expenditure remains very high. We are one of the poorest. But at the same time, this is one of the proxy indicators how the health systems are performing as a country. The progress has been substantial once we look at the kind of investments which in the health side, besides the COVID, which have been made over a period of time. But in the earlier time, when I started working in public health in 2003, after taking my premature retirement from Army, Air Force rather, and since then, different government programs and all the institutions, besides the government or in the non-government sector, we always spoke that there would be the quality of care. Everybody endeavors. Somewhere it was written. But do we have some data to tell us that what is the quantum of harm which the country faces because of poor quality of care? And in fact, about 5 years back, this path-breaking study came under the Lancet Commission, where the harm because of poor quality of care was put for India about 16 lakhs of people losing their life because of poor quality of care. And I know, I'm aware, and I'm humbled that I'm speaking among an academician, where it is also being spoken. And in that, if you can see the first row only, there is too much of data on this slide, but if you see the first row only, it says that 66% of the deaths which could be amenable because of appropriate quality of care, those could be, in fact, taken care of over a period of time. And in that context, in fact, like health program side, way back in 1992, when there was no RCH, or any other program. We used to have child survival and safe motherhood program. That time also, somewhere it was always mentioned that there would be the quality of care, and in fact under National Health Mission also. Subsequently, National Health Mission got launched in 2005, and subsequently in NHSRC, like I am privileged to have my ED, Major General Professor Atul Kotwal, sitting in the audiences. He has just joined. That NHSRC is the technical support organization for the Ministry of Health and for the state government largely. Generally looking at the health systems, health policies, advising the governments, and somewhere working with all the states and central government. And different, after launch of National Health Mission in 2005, 6, 7, many states, they came out with their own quality standards, started coming. Kerala is one of them, that Kerala CAST, they call it, Kerala Accreditation Standard for the hospitals. Gujarat tried out their Kaizen model, well-established workplace management tools. Ministry got concerned that what should be the roadmap for the health quality accreditation, primarily focusing on the public health system per se. And at that point of time, in fact, this I'm talking about, there was, NABH had just final standards, there were no entry level or the progressive standards. And this used to be largely the status in the country at that point of time. And then, these are the certain key findings out of that study which the ministry had commissioned through an external agency, and they made the strong recommendation that for public health system, since the needs are different, there is a requirement to come out with the specific standards for all level of the facilities. And ultimately, during that time also, only in 2005-06, there was a famous case, Ramabai versus Union of India. And as a follow-up, Honorable Supreme Court directed all the states to constitute the family planning committees. But that was mainly focused on the family planning services. Not from the health system per se, not for the whole of the hospital per se. And then the ministry constituted an expert group. And it took about, say, 16 to 18 months of the efforts to bring all the stakeholders on the board and to create an institutional framework. Because we had the varied system. Like one side we had the 8 EAG states, 8 northeastern states, even 3 states, say Jammu Kashmir and Uttarakhand, Himachal, where the needs were a bit different. And one learning we had that any model which is dependent on the external technical support, like a person coming from outside. And for us, accreditation is one of the byproduct. If there is no improvement taking place and if that improvement is not being sustained, the whole effort is futile. And that is a challenge also, that how do we ensure that we have that, the quality culture inbuilt in the working of any health facility which I am talking about. And it is a time consuming. And in that context, operational guideline for the quality assurance, I can see today, I met also during tea time from Odisha government, from Odisha NHM, we have got many my colleagues who are working in the states for the quality, they happen to be here. In 2013, the quality standards for the district hospital and the operational guidelines were launched, followed by in the subsequent year for the PHC, for the CHCs, it has been coming. So if you look over here, that in 2013 I mentioned, then in 2014, these guidelines came. In 2015, few of you may be aware about our Kayakalp initiative. Dr. D.K. Sharma is in the audiences, and he would recall, and I'm sure that he would vouch that it has made some difference somewhere. And subsequently in 2016, this Mera Aspatal, because all these initiatives are contributing somewhere for improving the quality of care. And as of now, there are 8,800 odd facilities are linked with the Mera Aspatal portal, including from All India Institute of Medical Sciences, Delhi, to the peripheral most facilities. There are few challenges which in fact we are trying to address. Maternal health, child health has been a priority for the country. So these Lakshya guidelines came. Then we did also some work on it, because improving the quality of care also means that other than, having the better experience for the patients, having an appropriate clinical protocols being in place. We also did some work on this, standard treatment guidelines. There are issues and challenges. And then in the subsequent years, in the most peripheral setup, health and wellness center, we will not go into the merit or demerit of this initiative. There are quality standards in place for all level of facilities. Last year, on the World Patient Safety Day, that is on 17 September, these guidelines, the operational guidelines have been revised. And this year, this Muskan initiative is basically for improving the quality of care in the pediatric setup. Because we realize that for whole of the hospital, going for the formal certification or accreditation at times is overwhelming for a particular facility. And on just about a week back, on 17 September, which happens to be the World Patient Safety Day, a self-assessment tool named Sakushal has been developed. And in the audiences, we can see certain subject matter experts who were part of this discussion, including General Jagtar Singh. So these INQAS, which I was just mentioning, they may meet the international and national benchmark, and National Health Authority and the Ayushman Bharat has given them recognition, and also the IRD, Insurance Regulatory Development Authority. And as of now, in fact, these standards and the training program, surveyor training programs, they are accredited internationally by the ISQA. And this is as of now the status. Where do we stand? Like globally, you can see there are about say 51, figure may have changed, 52 or 53 standards which are globally recognized. And in the country, these are the 3 standards which are recognized. Similarly, our surveyor training program is accredited by them, and we are working under leadership of our ED to get NHSRC as agency, and to get that. And this view file shows our basket as of now, whatever we have for the every level of the facility, and certain supporting interventions. In the interest of time, I'm not going to go into those details. And this slide shows that, okay, from the district hospital level to the health and wellness center level, there are well-recognized, well-established, internationally benchmark quality standards are in place. So now this has become, in fact, one of the key priority, quality and patient safety. And Union Health Secretary on the 1st October has told, in fact, all the states. And in its rollout, we are looking at an active collaboration, active partnership with academy. And recently, in fact, some time back, NHSRC has signed an open-ended MOU with the academy to take it forward. And General Behra mentioned about 13 CCHFW. Now in the 14 CCHFW, it has been mentioned that at least these are the facilities which the government is aspiring to go for the certification. Every year there is an exercise which gets taken that all the states are ranked, all the district hospitals are ranked by a NITI through an expert group. And in that also, government has said, and this is one of the, in fact, the criteria for the ranking of the states, for the ranking of the district hospital, that how many facilities are that quality certified. And these standards are basically process centric, mainly focusing on the process part, because we know there are challenges which are going to be there. And these standards starting from availability of the services, following the traditional Donabedian model from the structure part, and also measuring the outcome. And to get it operationalized, in fact, on 5th, during this CHFW meeting, we have come out with the Saksham portal, which is going to be there. So the program is totally, in fact, the government supported. There is no cost involved. And we have been receiving the request from a lot of non-government players. So to institutionalize this arrangement, at every level, now there is a team at the state level, at the district level, and the district hospital level, and team which is available to support the hospital administration. But we want sooner or later that hospitals should take over this initiative. So to summarize these in fact, all initiatives, there are institutional arrangement, standards are there, then training and capacity building, that is the one area where we are looking for the, in fact, the active support of the AHA for AIIMS-like institution. Will conclude. Okay. I'm told 5 minutes, otherwise I was going to conclude in a minute or so. So we are looking at the partnership with AIIMS-like institutions for in terms of building the capacity. I mean, creating a standard was one of the easy tasks. But how do we equip the hospital, the field level functionaries, even the health and wellness center, in the PHCs where normally there are 2 doctors or 1 doctor with a small, say 4 or 5 set of people. And even at NHSRC all alone or the state level all alone, it is just not possible. How do we replicate those models? That is a challenge, because as of now there are 1800 odd health facilities in the country which are nationally quality certified and about 5000 odd at the state level. Leave besides those program based, Laksh, Muskan, whatever is there. And the government is giving the incentive also to these facilities. So this is my last slide. And how do we change the mindset? Because in Kayakalp also we noticed that once certification or the accreditation is over, those efforts are not sustained. Second challenge is, as I mentioned earlier, scaling it up. That how do we scale it up? Sustenance is a challenge. Though the government gives the incentive to all the at least public health facilities, say district hospital, if it is a 200-bedded district hospital, 20 lakhs of rupees is given as an incentive, which can also be used as a personal incentive. Under Kayakalp, in fact, 3 crores of rupees, earlier it used to be the 5 crore, 3 crores of rupees are annual award is there for the Kayakalp winner, and 50 lakhs for the district hospital. So that is the quantum of incentive which the government is rolling out. Creating the benchmark is still a challenge, because we strongly believe that unless whatever we do, unless the things are benchmarked, it does not serve the purpose. We don't have much, I mean, for the secondary care, for the primary care level facilities, more so in the primary care when the focus is on the ambulatory care, we don't have national benchmark. I mean, we don't have benchmark for hospital-acquired infection for a country as a whole. For the district hospitals, when I'm talking about 800 odd plus district hospital, still there is a considerable, I mean, information asymmetry on both the parts. I mean, there are 3 important stakeholders, I mean, administrators, then service providers, whether it is doctor, nurses, and more importantly, patient and community. I mean, any decision when it is being made, it has to be. But somewhere the beginning has to be made, and at NHSRC we are trying to work it out. Lastly, to conclude, we strongly believe, other than what is written on this file, that, I mean, the low-hanging fruits are over. If we are serious about improving and getting the better health outcome in the country, for a health system as a whole, not only the public, but government, non-government, even organized services like railways, defense, ESI, quality is the way forward. Thank you very much.
Thank you also. Come here. As NHRC, there is a lot of developments in the last few years, and many of the AIIMS have come. And one of the Bhubaneswar AIIMS is like that only under NHRC, particularly concerned with healthcare. And there are about 10 AIIMS, fully established AIIMS are there, and few are with assistance. The upgradation is there in a few institutes. And there are ESI hospitals converted into ESI medical colleges. In Telangana, we have 29 medical colleges. Out of those, 2 are central. One is AIIMS Telangana, one is ESI hospital, ESI medical college. And there are 10 government colleges, 17 private colleges. So this part of healthcare personal development. Most of the employees are employed in these healthcare organizations. This is one of the best, good development as far as healthcare is concerned. And all of the new medical colleges in Telangana have the Department of Hospital Administration established, budget sanction departments are there in 7 new medical colleges across Telangana. Thank you. Questions for Srivastava. Okay.
Thank you, sir. Now I would request our chairperson, Dr. K.T. Reddy, to felicitate the speaker, Dr. J.N. Srivastava, sir.